Okay, thank you very much. Assalamu alaikum. Our today's class is the continuation of our previous classes. In our previous class, we have got the concept of creatinine concentration in plasma and also the creatinine clearance from the renal and their different formulas and their approaches. In case of creatinine clearance, we have assumed the different conditions for the not only for the adults but also the children and also some patients regarding among them obese and we have calculated some different formulas. What are the significance of the creatinine clearance? Now today we will start with the significance and then we will move toward the dose adjustment if we found any type of the change in the creatinine clearance due to the some changes in our physiological structure or some different parameters. Then we will write the first of all significance of creatinine clearance. Okay, number one, generally the normal creatinine clearance value indicate the kidney is functioning normally, and some diseases states that the pathological conditions are in elderly population, the creatinine clearance is likely to be altered, leading to the lower values of the creatinine concentration. If creatinine clearance is reduced, dose adequate of the drug that are eliminated by the kidneys are must be considered. Failure to adjust the dose of the drug will result much higher blood concentration of the creatinine, and an alternative to adjustment the dose of the drug is to decrease the frequency at which the normal dose is adjusted. For example, if the normal dose is 250 milligram, there are three different approaches when we want to adjust the dose. Either we can reduce the dose of the drug, another is we can increase the dosing interval, and third one is we can apply the both situations according to the need of the patient. First one is decrease the dose. This is not acceptable in many cases, but in some cases we can use the same technique. But other is we can increase the dosing interval. For example, we have to give the patient the drug in TID, then we can increase into then the QID, into the BID. We will increase the dosing interval. So after not only 8 hours, we will give it after 12 hours. In other cases, we can reduce the dose. Reducing the dose meaning we want to give the patient drug 250 milligram and now we are giving the 200 milligram. This is the reduction of the dose. So the third one is both combination. The lower creatinine concentration values will affect so-called constant parameters such as the elimination and excretion rate constant, elimination half-life, and possibly the apparent of volume of distribution, because we know VD depends on the clearance and KVD. We know clearance is equal to KVD, and when we assume that these parameters Ku is changing and clearance is also getting some changes due to the change in the creatinine clearance, then VD, which is actually a permanent or a constant parameter for the drugs, but we can see some changes in the apparent volume of distribution, and also there in turn we will influence the values of any other pharmacokinetic parameters mathematically related to them. This example is for one compartment model. The parameters include plasma concentration at any time, the area under the concentration versus time, and clearance. These are the parameters which can be changed. Okay, we have different concepts of the concentrations. For example, we know we have the Cp is equal to Cp naught E minus Kt. I want to clear the concept of this rate. When we change the rate of change of concentration in urine with respect to time, it means we have a change in the concentration of plasma concentration also. When we change the rate of change concentration Ku, then we will also see the change in the clearance and also the Vd. We have also the formula of T half 0.693 over K. This K is also directly affected with the rate clearance rate of the creatinine clearance. So we can assume that these parameters can be changed for, and same case in case of AUC, area under the curve, which is equal to dose over clearance, because clearance is equal to dose over AUC. So clearance is equal, AUC is equal to dose over clearance. So when we see the clearance, we can write here dose over KVD. So this K will once again change the scenario of these parameters. So we can assume that there is when we are discussing with the IV injection drugs, and we can assume that these parameters are directly influenced with the rate constant, and these rate constant are changes with respect to the change in the creatinine clearance. So we have different parameters, different values of clearance. In case of the patient which are showing us the less creatinine clearance, we will have the different value of the rate constant, and ultimately we will get the different value of clearance. Same case, plasma concentration will be changed. Plasma concentration of creatinine will be changed. When we are getting the lesser rate, then we will get the difference of the plasma concentration of creatinine. Half-life will also be getting some effect, and having the inverse relation with this rate constant, and then we can assume that there might be some changes. Area under the curve will also get some changes. These are some factors in case of when we are discussing the one compartment model and IV injections model. In case of orally administered drug, we have another concept. In case of when we are discussing the oral administered doses, and we are plotting some concentration versus time graph, and we are getting some information in which we have some constant values, and in this case we will assume two rate constants. One is Kn and other is Knr. Kn and Knr both are the rate constant, and Kn is basically normal renal function rate constant of the normal renal function, and this Knr is rate constant of renal impairment, rate constant for severe renal impairment. These both rate constants will give us some information regarding some relationship, and there is the table in which some different drugs are given, and their Kn and Knr values are written. And in this table we will divide these groups into A to L, and in case of these groups we have some different drugs and their Kn values, rate constant for the normal range and rate constant for the renally impaired range, and then we will divide these for example, there is a group, okay, name of drug, Kn value, Knr value, and Kn divided by Knr into 100. This is basically ratio of the rate constant in normal condition when the renal function is normal, and when the renal function is compromised, then the ratio, we will get the same scenario. Okay, when we see this table, we can assume that there is a relationship between these type of the rate constant and with the half-life. And this type of the graph you can see in Leon Shargel, where they have assumed the effect of the half-life, relationship between the half-life and also the these ratio of the Kn over Knr, and this graph is figure 24.4 in the Leon Shargel and table 24.5. Same case in the Sunil Jambekar, there is a table 4.2 which will give us the information of the difference in the rate changes. So when we have the difference in the rate changes and we assume that the ratio will also be changed, and this type of the ratio will give us the some concept regarding the changes of the half-life and the some other parameters. We will make a lab in our future coming labs. I will give you the data, and we will apply this type of the condition, how many parameters are getting changed when we are observing some type of the rate changes in the normal value and also in the renal function value. Okay, another concept is how can we correlate this clearance with the glomerular filtration. And glomerular filtration rate is a parameter which will give us the actual concept of the clearance. And there is a direct relationship with the glomerular filtration rate and the clearance. And we have another observation, especially in case of glomerular filtration rate, we can check the different parameters and the different conditions of the glomerular filtration rates. There is also a table in Leon Shargel, table 24.3, which give us the classification of the renal function based on the estimated GFR. Classification of renal function based on estimated glomerular filtration rate. Okay, there are 5 stages. A description, estimated glomerular filtration rate in ml per minute per 1.73 meter cube body surface area, and creatinine clearance ml per minute. What we are studying, we are just getting the concept. Glomerular filtration rate is directly giving us the information of the creatinine clearance. Okay, stage 1, when we are assuming that was stage 1, it's normal GFR and value is more than 90. Creatinine clearance will also be the more than 90. Now stage 2, mild decrease in GFR 60 to 89, and creatinine clearance value will be also 60 to 89. And in case of 3, moderate decrease in GFR 30 to 59 and 30 to 59. Okay, 4, severe decrease in GFR 15 to 29 and creatinine clearance is also 15 to 29. Okay, stage 5, end stage renal disease. And less than 15, not on dialysis, required dialysis. Same case, less than 15, if not on dialysis, required dialysis. So we can assume that when we have an accurate volume of glomerular filtration rate, then we can assume that there is a direct relation with the creatinine clearance. Same values and the same conditions. If we found the normal GFR, and normal GFR is more than 90. We have already discussed in our previous classes, the normal value of creatinine clearance is in adults, male, 108, in female, plus minus 20, and in male, that was 120 plus minus 20 ml per minute. And same in case of more than 90 means we are moving toward that area which we are assuming that the normal value. But when we have the mild decrease in the GFR, it means we are discussing the three conditions which is 60 to 89 ml per minute per centimeter per 1.373 meters square, which is actually the body surface area, and also the creatinine clearance 60 to 89 considered as a mild decrease value. It's a stage 2. And in case of stage 3, we have the moderate decrease in GFR, that is 30 to 59, and in case of creatinine clearance, that is 30 to 59. But in case of when we are moving toward the severe decrease in GFR, the value of GFR is glomerular filtration, eGFR, estimated glomerular filtration rate is 15 to 29, and in case of creatinine clearance, it's also 15 to 29. But when we are at the severe condition, that is end stage renal kidney disease, and that is a stage 5, and when we are assuming that this concentration of the creatinine and the eGFR is less than 15, and patient should be on the dialysis so that the function of the body can be assumed in the normal way. Okay, question is, how can we calculate the estimated glomerular filtration rate? How can we calculate this eGFR? Because when we have the eGFR, then we will assume that it's creatinine concentration, creatinine clearance, and then we can suggest the normal or the adjusted doses of the patients. Okay, there are the 3 basic methods to calculate the eGFR. Remember, eGFR, now we are using the word eGFR, which are actually discussing about the creatinine clearance. We have already used the different formulas for the sake of calculations of creatinine clearance in the case of adults, and now we are moving toward the estimation of estimated glomerular filtration rate. There are 3 basic methods. One is modification of diet in renal disease. Modification of diet in renal disease, also called Mdrd method. In case of Mdrd method, we will assume that when we discussed the calculations of the creatinine amount in the previous classes, where we use the Cockcroft method, and the Cockcroft method and the Mdrd method. They are both are the comparative, because Cockcroft method we have used the formula in the case 140 into minus the age of the patient, and then uh, body weight. And in case of there are the two concepts. One is MDRD for EGFR, and other concept is application of the uh, Cockcroft method for creatinine clearance. I will write in the both in the comparison form because we are using the both, but the most acceptable is MDRD method. Why it's most acceptable? Because in case of this method, we have just tried in the very few patients, but this method has been tried on the large scale, large number of the patients. In Cockcroft clearance method, creatinine clearance was calculated by 140 minus age and its body weight divided by 72 into creatinine concentration in milligram per deciliter. This was the formula which I have already written in my previous class, and we know what parameters we required. One is age and other is the weight, and creatinine concentration, normal creatinine concentration, that was calculated by the simple formula. And also we can assume that the normal values, normal ranges for the male and female, and then we can assume this creatinine clearance value by using this formula. And in comparison of when we are discussing with the glomerular filtration rate, then our formula is in case of MDRD method, and we want to calculate the estimated GFR. What parameters we need? We have to multiply 186 with concentration, systemic concentration of creatinine, multiply by 1.154 into age, power is 0.2203, multiply by 1.212 if black, and multiply by 0.4742 if female. This is MDRD method. Modification of diet in renal disease. Remember what we are discussing? We are discussing that glomerular filtration rate and the creatinine clearance both can be calculated, and both have the same scenario of application for the adjustment of dose in the renal impaired patients. And calculation of creatinine clearance I have already told in my previous class. Now we are discussing how can we calculate the estimated glomerular filtration rate. Among them, one method is MDRD method, which is modification of diet in renal disease case patients. And the other approach is, in the case of, for the sake of estimation of glomerular filtration, is quadratic formula. And the third one is chronic kidney disease epidemiological collaboration formula. Chronic kidney disease epidemiological collaboration formula. There are three basic ways to calculate the estimated glomerular filtration rate. And in case of MDRD is a unique method which will give us the accurate measurement of the eGFR, estimated glomerular filtration rate, which will give us the idea, okay, at what stage of the patient is. Then we will decide the dose according to the stage of the patient. Either he is in mild, in moderate, in severe or normal. Then what we need for the calculation of estimated glomerular filtration rate by using the Mdrd formula is, there is creatinine concentration in systemic circulation, age, and there is a factor for the people who belongs to the black. And if we are discussing with the female, then we will have to multiply with the factor 0.742. If we are discussing with the white and the Asian people, then we will exclude these two. We will not write this one and also this one. Then we will need only creatinine concentration and the age. Remember, there is also creatinine concentration, age and weight. But this formula, as compared to this one, this is the most common used formula when we are calculating the creatinine clearance, and this formula is considered more accurate, more reliable as compared to this one. Okay, the other formulas, in case of when we are discussing the Mayo's quadratic formula, it's also a lengthy formula, but we can, if you want to see, then you can see in the Sunil Jambaker book, where is a detailed given in the, especially these two formulas. We are not working on that. We are just working with the Mdrd method and also with the Cockcroft creatinine clearance method, and our comparison between these two. Okay, now how can we check the calculations, do the calculations of the adjust the doses of the drugs? We will check the first, for sake of the adjusted dose, we will have two parameters. One is our normal fraction of the drug, normal dose of the drug, and other is which we are adjusting. So the formula is adjusting daily dose is equal to x naught NRF, normal renal function, multiply by patient's creatinine clearance divided by normal creatinine clearance. Patient's creatinine clearance divided by the normal creatinine clearance. We will check the patient's creatinine clearance first by using Mdrd method or the Cockcroft method, and write with the normal, which is 110 for the male, 108 for the female, and write the dose which is given to the normal patients having the normal renal function, and then we will obtain this one. When we see the critically this formula, we know this value will be greater always, normal creatinine value. Normal creatinine clearance value always will be greater, because we have just discussed the estimated GFR for calculation, where we are using the 5 different classes: normal, mild, moderate, severe. And in case of when we are deeply looking at the table, we are assuming that there are the decrease in the renal clearance and also the decrease in the estimated GFR. So this decrease will give us, when the denominator values are lesser and the numerator values are higher, we will get the answer in the some points less than 1. When we are getting the answer in less than 1, we will multiply this factor with the normal dose, and this normal dose will be given to the patient. Now the condition is, how can we have to serve the patient with the modified dose? We have 3 approaches. I have already told you. We can give we can increase the dosing interval, we can decrease the dose amount, and we can apply the both conditions unanimously on the same patient. to getting the to preserving the same side effects of these the normal doses of the drug. When we are moving towards the Lyon Chargel, there are the three other ways to adjust the dose, to adjust the dosing adjustment of the dose adjustment based on the drug clearance, and also dose adjustment based on the change in elimination rate constant. There are the two basic techniques when we are looking on the pharmacokinetically. If we are looking the adjustment regarding the drug clearance, then there is the same formula which I have already told in so many times. For example, dose over clearance, and then the other are the other FD naught over clearance. These are all those formulas which I have already told you in my previous classes. So there is a general approach which we have, which will focus in our lab also. We will adjust the dose of those patients who are on the different conditions of their renal functions. Then we will assume that, okay, how much dose is given to the patient and what are the dosing interval and what should be the parameters which are giving us some information and getting some changes as we are assuming the change in the creatinine concentration. So with this, thank you very much. You should have to learn this measurement of glomerular filtration rate and also their relationship with the creatinine clearance. And I have given another concept of the effect of the rate of the drug clearance of the drug on the normal value, and also their renally compromised, renally impaired patients, then their ratio, and other is the effect of the estimated glomerular filtration rate and their relationship with the creatinine clearance, and how we can calculate the EGFR, estimated glomerular filtration rate, and how we can adjust the dose for the renally compromised patients or the patients who are on the different stages of the renal failure. So if you have any question, then you may ask me through your comments, and also you should have to read this the chapter from the Lyon Chargel and also the Sunil Jambekar. Thank you very much.